Yes.
It's my great pleasure to discuss with you today different techniques that are used for patients with lens subluxations and ectopias. The main surgical goals in these patients are to preserve capsular bag for IOL fixation and to provide stable IOL position in the long term postoperatively. There are several devices that can help us to stabilize the capsular bag during surgery, such as capsular hooks. There are many useful devices that can be sutured to the sclera and provide long-term capsular bag stabilization. Capsular tension rings of various types are among the most popular. They can be utilized in the variety of clinical conditions from relatively mild to very severe zonular instability. Malugin modified CTR is having an eyelet that is moved to the very tip of the device. That make it much easier to implant into the eye with the help of the injector. Over the years, my preferred suture was 90 polypropylene. However, quite recently, Gore-Tex was also introduced into my clinical practice. With polypropylene, having both ends of one suture attached to the same needle, forming the loop, it is quite easy to use the co-hitch type of suture attachment to the eyelet of the CTR. After exiting the eye, the suture is fixed to the sclera with zigzag technique proposed by Peter Schurman. L-shaped incision of the conjunctiva is made, and the needle is passed parallel to the limbus 4 or 5 times. Here is the clinical case of the patient having Marfan syndrome. As shown here, capsulotomy is initiated with their microforceps. Following that, the capsular bag was stabilized with the special capsular hooks introduced through the opening in the anterior capsule, as shown here. And this is a very useful device because the tip of the capsular hooks rests at the equator of the capsular bag and does not cause a lot of stress on the edge of the anterior capsular axis. Following by aspiration of the relatively soft cortical material, CTR is introduced into the capsular bag, and we can see that suture is attached to the eyelet of the CTR, and after rotation of the fixation element into the proper position, we release the capsular hooks, we reposition the fixation element on top of the anterior capsule, as shown here, and that passes the needle through the ciliary sulcus outside of the eye, and then aspirating the residual cortical material from the capsular bag, implanting IOL in the capsular bag, and positioning it the way that the haptics of the lens are not interfering with the position of the fixation element. Certain anatomical considerations should be kept in mind when utilizing the Z suture. First, relatively wide scleral exposure is needed. And second, there is not enough space for the suture when the needle exits close to the rectus muscle. Over the years, this technique showed us the stability of the implant and the reliability of the clinical results. And you can see with the blue arrows the location of the CTR in the capsular bag and also the intrascleral path of the suture. We performed this technique with a great success. However, 2 years ago, the patient came back to us after 5 years following implantation of the CTR and suturing it to the sclera. And you can see here that the IOL is dislocated. The suture is located under the conjunctiva, and during the surgical procedure, when we inspected the area of the suture, we observed that there is a suture break that happened over these years. This patient needed refixation of the capsular bag with another suture, and this problem was resolved. We use scanning electronic microscopy to examine the suture, and we've seen a significant amount of fire degradation of this 9-0 polypropylene material, as shown here. And also, we observed the thinning of the tips of the suture directly attached to the eyelet of the CTR. Starting from the case, we finished using 9-0 polypropylene, and this is current technique, which is illustrated by this video fragment. As shown here, there was a significant lens subluxation. Now, fake emulsification is being performed with the help of the capsular hooks that are supporting the capsular bag, and you can see here that the lens is quite stable. Now I'm injecting modified CTR inside the capsular bag, while there is some cortical material still present, with the reason being to avoid aspiration of the equator of the capsular bag, which is not uncommon in that kind of surgery. In spite of the capsular hooks that are in place, there is still a gap in between them where that issue may happen. I decided to attach the cortex to the eyelet of the CTR without doing it outside of the eye. Sometimes it's much more helpful to do it that way. For that purpose, I'm using two 25-gauge forceps. Bent 25-gauge needle will be used to introduce the suture through the ciliary sulcus and go out of the eye through the sclera. As shown here, this is one tip of that suture that is passed through the sclera, and I will be using the same needle to pass the second portion of that suture and again go out from the eye in the area adjacent to the first exit. The ends of the suture are trimmed, and it's time to implant the IOL into the capsular bag, because the later is stabilized with the CTR fixed to the sclera. And this is a hydrophobic acrylic IOL that goes into the capsular bag that unfolds quite slowly in the controlled fashion. So I will be able to guide the haptic into the capsular bag, and then, which is very important step, station of the knot inside the sclera. My preferred technique in patients with significant zonular dialysis and lens subluxation is based on capsular bag stabilization with the modified CTR. I do think that Vortex is the best current option for CTR suturing, and this technique is being a viable alternative to the iris flow, scleral or iris sutured IOLs, and even flanged IOL CTR techniques. And I thank you very much for your kind attention.